Welcome back to Clinical Rounds. Today, we're executing the 280+ protocol. As a dermatopathologist and infectious disease consultant, my goal for this explainer is simple: to help you filter out the diagnostic noise and instantly identify life-threatening medical and surgical emergencies. We've got a hyperdense clinical roadmap to cover today, so let's just jump right in.
Here's our agenda. We'll be tackling 3 high-stakes diagnostic modules: life-threatening dermatoses, the fever rash chronology, and surgical soft tissue emergencies, before finishing up with a mandatory validation drill.
All right, Module 1, life-threatening dermatoses. We are zeroing in specifically on the plane of separation.
To really master these dermatoses, you've got to understand the first principal concept here, and that's anatomical depth. We're looking at 2 radically different mechanisms. On one hand, you have a deep, drug-induced immunological hypersensitivity. This attacks right at the dermal-epidermal junction. On the other hand, a superficial cleavage caused by bacterial exotoxins hitting the stratum granulosum. Nailing this depth is absolutely crucial to cutting through the clinical noise.
Now, let's put Stevens-Johnson syndrome and staphylococcal scalded skin syndrome side by side on the judge's bench. The patient profile and mucosal involvement, those are your absolute anchors here. You're basically pitting an adult with a drug-induced reaction and severe mucosal necrosis against an infant with superficial toxin-induced sloughing. And the kicker? The infant's reaction entirely spares the mucous membranes.
Take a look at this. This right here is your clinical anchor for SJS. Severe hemorrhagic mucosal erosions on the lips and hands. This specific finding is what separates SJS from the distracting noise of just, say, a generic upper respiratory infection or some benign viral exanthem. Look, if you see severely involved mucous membranes right after a patient starts a new drug like allopurinol, your alarm bells should be ringing loud and clear.
This mechanism directly builds our severity invasiveness scale. And for this, we must strictly quantify the body surface area, or BSA. Less than 10%, that's SJS. 10 to 30% is an overlap, but 30%, that is the critical threshold. Crossing that 30% line means you've progressed into toxic epidermal necrolysis, or TEN. At that point, you are immediately shifting management from supportive care to an intensive care burn center. We're talking massive fluid loss and lethal infection risks here, so you've got to move fast.
So the golden rule in our pathology variance box is actually pretty simple. If you have an infant with skin sloughing under gentle pressure, which we know is a positive Nikolsky sign, but their oral mucosa is completely intact and ulcer-free, you are looking at SSS. Why? Because that bacterial exotoxin simply does not possess the ability to cleave mucosal tissue. It's just not happening.
Okay, moving on to Module 2, childhood exanthems, where we'll focus on the fever rash chronology.
When we're evaluating viral exanthems, timing is literally everything. For measles, the timeline starts with a prodrome of high fever and the classic 3 Cs: cough, coryza, and conjunctivitis. These last for days before you see any skin eruption whatsoever. Next up, Koplik spots appear, followed ultimately by a rash that spreads systematically from the head all the way down to the trunk.
As you can see here, that classic cephalocaudal shower distribution is the hallmark you're looking for. But the true harbinger? The Koplik spots. These tiny, irregular red spots with gray-white centers erupt inside the mouth, right on the buccal mucosa. They are completely pathognomonic for measles. And the best part? They actually precede the main body rash, which gives you a massive early diagnostic lead.
Putting measles and rubella on the judge's bench reveals 2 very different clinical contexts for a head-to-toe rash. Measles hits hard, with a high fever. We're talking often around 104 degrees, in a severely ill-appearing child. Rubella, on the flip side, features a low-grade fever, a relatively comfortable child, and prominent post-auricular lymphadenopathy. That just means swollen nodes right behind the ears.
To filter out the noise of a generic fever and rash presentation, you need to anchor onto the severity of the fever and the specific location of those lymph nodes. High fever plus systemic toxicity, that equals measles. Mild fever plus post-auricular nodes, that equals rubella. Simple as that.
Let's jump into Module 3, surgical soft tissue emergencies. Specifically, necrotizing fasciitis versus cellulitis.
Missing this transition can literally cost a patient a limb or even their life. The fundamental pathophysiological divide we're looking at here is anatomical depth. Cellulitis is a superficial dermal inflammation. It gives you a warm, erythematous, well-demarcated plaque. But necrotizing fasciitis, that is deep fascial destruction.
Early on, the skin might not even look terribly red. Instead, it rapidly spreads and takes on this dusky, purplish hue while the underlying tissue quietly dies.
This situation requires aggressive signal-to-noise filtering. The noise here is usually a distracting patient history. Maybe they mention a minor bug bite or a tiny scrape. You need to ignore that. Your true clinical signals are systemic toxicity, palpable crepitus or gas under the skin, and crucially, pain that is just drastically out of proportion to the visible skin exam.
A patient's hemodynamic stability maps directly to your intervention. If you've got a stable patient with a well-demarcated plaque, they get antibiotics. But if they are critical, presenting with shock or that crazy out-of-proportion pain, it dictates the exact moment you stop relying on meds and rush them straight to the operating room for surgical debridement. As this algorithm clearly shows, if you suspect necrotizing fasciitis based on systemic signs or an elevated LRI-knee score, you consult surgery urgently. You absolutely do not delay surgical exploration just to wait for an MRI or CT scan if the patient is unstable. Remember, time is tissue.
Here is your definitive clinical triad. If you palpate crunching crepitus beneath dusky blue skin in a hypotensive patient, you are looking at a critical emergency. The definitive treatment is immediate surgical debridement under general anesthesia, paired, of course, with broad-spectrum antibiotics.
All right, on to Module 4, the mandatory validation drill. Let's see how all of this applies clinically.
Let's evaluate Vignette 1. We have a 45-year-old male who started allopurinol 2 weeks ago. He presents with a fever, painful blistering lesions over his chest and mouth, a positive Nikolsky sign, and a biopsy showing full-thickness epidermal necrosis. Take a second and think about your anchors here.
Because of that allopurinol trigger and the severe mucosal involvement, this lands firmly on the SJS/10 spectrum. This heavy mucosal destruction is exactly what definitively separates it from staphylococcal scalded skin syndrome, which, as we know, classically spares the mucous membranes entirely.
Now for Vignette 2. A 60-year-old diabetic male presents with a red, swollen right leg. His temperature is 103 degrees Fahrenheit. Blood pressure is 90/60. On exam, the skin appears dusky blue with palpable crunching underneath. What is the single most appropriate next step in management?
Well, the hypotension and that crunching crepitus are massive signals cutting right through the noise of a simple red leg. This is necrotizing fasciitis. Therefore, the only correct next step is emergent surgical debridement under general anesthesia. Again, do not wait for imaging.
To wrap up this explainer, I want to leave you with a provocative thought. When faced with an undifferentiated patient experiencing rapid skin changes, your ability to filter noise literally saves lives. But ask yourself, in the heat of the moment, will you trust the subtle physical finding of out-of-proportion pain enough to completely bypass the scanner and go straight to the OR? Master these clinical anchors, and you will never hesitate when it counts. Thanks for joining me on Clinical Rounds, and I'll catch you in the next explainer.